Oh, now it's getting bigger. The patient don't see with the saliva on top, but I can see very well. It's a big problem. 8 months, 1 year. It's growing and growing. What should we do now? Now I have a problem. So from here, it became this. Never underestimate the tuberosity. So I waited until it stopped growing. And I used diamond burrs. And I left this coagulum on top in order to create a barrier of coagulum. And I protected the coagulum with the periodontal cement. I made a very deep de-epithelialization. It's getting better. And this is 1.5 years later. The patient is happy because with saliva on top, she sees nothing. Nobody can see at normal distance that there's something wrong. But this is the fixing of a mistake. And I want it to never happen anymore. Never. This is 2 years later. Now she's fine. Now I can go with the final and I can push a little bit up here. I have too much tissue, but I can manage. But I prefer you to know what are the risks before seeing what is the good. Now I'll show you how you should use it. She's a syndromic girl. She has multiple agenesis. Many teeth are missing. And the volume of the enamel is different from normal people. Very thin teeth. We have to place 2 lateral incisors in a very narrow bone and narrow tissue. There's a very narrow and tight space between the roots. So I will use the minis. Here. Guided surgery is one option. But if you're not an experienced, you can use your finger guidance. You put your finger here and you feel where the root are. And you go straight up to the tip of your finger. But this is for very experienced people. Otherwise, I suggest a guidance. Because you risk to do a apicectomy. And this is a blinded procedure because it's a closed flap procedure. Blind procedure. I didn't open a flap because I would have lost this papilla. Because the implant is very near the teeth. This is a custom abutment and I remove the excess of tissue with this is a ceramic burr. It works like a laser. I have the laser, but this is faster for these things. Place provisionals. This is 1 week. We are waiting for the orthodontics to finish. This is the implant positioning. Very narrow space. Six months. Still see there is a missing volume here. So we will increase this volume for aesthetic purpose, and in the meanwhile we will fix with the crown lengthening of the two canines. Because you see that the canine is very, very little. And this woman will do veneers in all the frontal teeth. No prep veneers, no preparation veneers. So this is the bone remodeling around the canine. Tissue is repositioned. And then I go in the tuberosity, which is very big. When you see a big tuber, expect a big growing. This volume will be for both the sides. So I will deepitalize this, and I will split in two parts, very little piece. I like to call them seeds, the baobab seeds. The baobab is a big tree that grows in Africa. The seed is very little, but after it becomes immense. How do they use it? I go inside with the suture. I come out here. I grab the very little baobab seed, and I go back in the tunnel, and then I close this, and the baobab seed goes inside. So first, you have to make a tunnel with your blade inside. Half thickness. And then you grab this and go back. And you pull it in position. And then you close the suture. But because we learned the lesson from my mistakes, the baobab seed has to stay very deep, far from the surface, distance. Otherwise the bees comes out. Six months. Now we have a better volume here. Now we have to do the smile design. I do analogic smile design, not the Christian Kochman one. This is the wax up. We put the mock-up in place. So it's a replica of the wax-up. We use this to study the function and the phonetics and the aesthetics. And then we are ready for the final veneers. No prep veneers. Very thin. There is a nice contour that simulates the root positioning. The volume is more than enough in both sides. So these are M-press veneers, Emax, and these are zirconia ceramic crowns. I don't like to do disilicate on top of metal abutment. You can, but could be a biomechanical risk over time. Zirconia core is stronger. Veneer in place. This is the end up of the smile. This is 2-year follow-up. There is a nice root emergence on the lateral. Unfortunately, you can see a little bit a scar. This is the scar from the crown lengthening of the canine. Four-year post-op. She's brushing a little bit too hard, so we changed the stiffness of the toothbrush. Before and after. And she smiles like this now. Now I present you a very, very difficult case for me. Tell me when you want to do any break. You tell me 10 minutes before. Oh, you want break? Perfect.
Dạ rất là tốt chị, về trang thiết bị rồi từ trang thiết bị nè, rồi thức uống cho bác sĩ cũng rất là tốt. Với lại nhân viên cũng rất là nhiệt tình.
Về nội dung học thì chị có ấn tượng hay là chị cảm thấy nội dung có giúp ích gì về trong chị
Thầy rất là dễ thương, với lại nội dung nghe cũng rất là dễ hiểu. Dạ, dạ.
Về mặt tổ chức ấy, thì thấy công ty tổ chức rất là chuyên nghiệp. Thì về mặt âm thanh ánh sáng, về người phiên dịch thì giúp cho học viên rất dễ dàng tiếp cận được cái bài giảng của bác sĩ. Đó. Còn thứ hai về mặt nội dung của chương trình thì bác sĩ đã mang đến những kiến thức cập nhật mới, những cái cần thiết và những cái sai lầm trong cái điều trị của bác sĩ để chỉ dẫn cho mọi người, từ đó rất là thực tế và giúp cho mọi người trong thực hành lâm sàng rất là nhiều.
Dạ, em mời quý bác sĩ quay trở lại để bắt đầu vào buổi diễn thuyết tiếp theo của Davide ạ.
I would like to present you this. This case is difficult because of a reason. Perhaps you can have complex surgeries, but surgery is never difficult. Perhaps is complex, has many parts. I will wait for people to sit. Thank you. But this case is complex and it's difficult because the patient is difficult. Not because the case is difficult. The case perhaps is complex, but we can have difficult patient that makes simple things become difficult. This patient has many problems. We will fix them, but here he has what he thinks to be the most important problem. There is a bone resorption in the frontal teeth. There is a root resorption, and this tooth has mobility 3rd grade. So, if he snores, he will pull the tooth into your eyes, like achoo. The bone peak medial is missing from 4 millimeter. The distal bone peak is missing by 6 millimeter. And he has already a recession. The request of the patient, immediate loading, very cheap, very fast, no bone regeneration. Perfect. This is very difficult. First of all, I told him, cheap is impossible. Fast, perhaps. But we need to regenerate the bone. Because this is a fake position of the tissue. When I remove the tooth, this tissue will go here. This papilla will disappear. And this tissue will go here. Because the bone is too far. But the patient said, okay, I can pay, but I don't want bone regeneration. Why? I don't know. So I said that there is a very good dentist next to my door in the same building. My office is in the center of Milan. In my building there are 8 dentists. Why do you come to me? When I went back to my office, my internal office, there was my assistant like this, very angry. And that was the second big problem, because this was her uncle. I said, you go there and you put a tooth very fast and without bone regeneration. And this is my main assistant. I work in a family office since 3 generations. The uncle of my father was a dentist. My father is a professor in orthodontist. My brother, who's little, makes orthodontist, and I do prosthodontics and surgery. It's 17 chairs. But this assistant is the commander. She manages everything. And I'm very scared if she gets angry, because my business go down. So I had to find a way to fix the recession, to try to give ideal aesthetic without bone regeneration in a difficult patient. And there is also a horizontal missing problem. I must be very careful to treat this case. Fortunately, I think at my superpower seed of baobab. It can compensate the missing volume using the phenotype modulation. Between all the grafting that I have in the mouth, this is the less painful. And also has the tendency to expand. In this particular case will be my first choice. When I can, I use the surface one, because it's stable and more manageable. But now I need superpowers. To make it very cheap, I take a silicone impression before, after doing the direct mock-up. This is the direct mock-up. This became the final restoration, I discovered later. Here's the surgery. Music, please, from the computer. Music from the computer. Thank you so much. Again, this is the removal of the teeth. There's no music from the computer. Bad for them. It's a good music. You see the bone peaks in 7
Sometimes I give myself the creeps. Sometimes my mind plays tricks on me.
It's a surgical pocket, tunneling technique. Again, distally oriented and very palatal. They don't like the music from my computer. I'm going very slowly because I tried to collect some bone, but I couldn't. Here's the implant. The very wide threads can give me a lot of stability. You see the black line? It has to stay just next to the gingival line, so it's deep 4 millimeters. Put back in your post-it. 81 ISQ is really high. Then I go to the tuberosity. It's always the same. Very little piece, 1.5 millimeters far from the teeth, and never cut the soft palate. I straighten the rod until it becomes straight. I go tunneling. I deepitalize before, and I go back in the original position. I will use this baobab seed to increase the buccal volume and the interproximal mesial papilla. Because they are the most important areas. This will behave growing. But it has to grow from the inside. So the aesthetic of the tissue will not be harmed. This is the implant positioning. Slightly distal, slightly convergent. Palatal. You see the graft is inside the tissue. It's far from the surface. I might build my abutment, polish perfectly, shoulderless preparation. Because of this, one abutment one time, so I will not remove, not to have recession. If you want before placing to the implant, to the mouth, you take an impression of the abutment mounted on analog. You close the hole and you take the impression. It helps you to give the technician all the information for the crown. This is silicone of the mock-up. I put inside self-curing resin and I close the hole. You will see this technique after if you want. And in counterprint with the silicone, I create the crown. Self-curing resin with the silicone back in position is the replica of the original tooth. If you want, and if the tooth is healthy, you can empty and reline the tooth, the original tooth of the patient. Can be an option. As I told before, it's a big risk not to use a silicone dam, an isolation material. I follow this risk because I want to read the shape of the tissue. But I suggest for the one who are not experienced to put a dam, because if the resin goes inside, the implant will fail. So I polish very well to have a horizontal emergence profile. You see the crown seems to be too buccal.